All right, guys, we'll go ahead and get started here. So, welcome. It's nice to see all your shining faces here. Thanks for getting here safe. This is the best attended FTO meeting ever, so congratulations. Good to be here with you guys. So, guys, today is a really big day. You know, the EMS division has been working really hard in the background to make this program great. And we've worked with a number of agencies, the hospital, their blood bank, the lab, the trauma department, the ER, nurses and physicians. It's been a lot of organizing, and it has been probably the biggest project that I've ever undertaken. And so a lot of players in this. And I'm happy to finally see this is like game day. This is like the Super Bowl. It's finally happening. So today we kind of pass the torch to you guys as the FTOs. And one of you guys in this room will probably be the first ones to give pre-hospital blood in our system. So it's pretty exciting. But this program is not going to be successful without your help and without your buy-in. So we're going to talk about it today. So yesterday, like Chief Jones was saying, we went for a field trip to the blood bank. And you can see they've got all that blood there in those coolers. Just for the EMS captains in the room, the way you access this is you go in through the normal ED doors, and then you go past the charge nurse station and go to room 6. You can see there on the left. And basically, there's a code there. It's the same code as you get into the ER. So you guys know that code. It's 911 pound, and then that gets you into the hallway. Captain Waller has a directions and a map for EMS 1. And then to get back in, you can use the same code. Previously, they had a badge in. Once you got stuck in the hallway, you couldn't get back in. So now you can. So this is the blood. This is what it looks like. You can see it's kind of separated there. And then on the right, that's the actual blood that we gave. There's this little marker on it called a time strip BT10. And that BT10 just means like blood temperature 10 degrees Celsius. If it ever goes above 10 degrees Celsius, that blood is no longer usable. And so how will you know that? Well, when you see that it's good, it's got that white stripe, and when it's not, it turns into blue. Okay? Everybody clear on that? We'll talk about this more in detail later, but that's how you know that blood has gone over that 10 degree magic temperature and it can no longer be used. Okay? The blood is always stored at a cool temperature, 1 to 10 degrees Celsius, but when we give it, obviously we warm it up, and we want it to be warm, and we'll talk about how that works specifically. The short version is you got about 30 minutes before that tag turns blue, and then you can still put it back in the cooler, but if it's blue, it cannot go back in. So blue is bad, we don't put it back in the cooler. When that blood is warming up, we have what's called the 4-hour rule. And so you have about 4 hours to give that blood. And the reason why is because bacteria actually starts to grow in the blood, and then it's no longer usable. It's not safe for the patient. So we actually simulated a patient yesterday. And so you can see somebody familiar there got some blood yesterday. And we had the staff there kind of test it out. We wanted to try to work out all the bugs before we went live. By the way, we're planning to go live on February 16th. So a lot of good questions answered yesterday in terms of, ESO documentation, Pulsera documentation, how to scan in the blood, how to document it, and we're going to teach you guys about that all today, okay? All right, so what's the plan for today? We're going to learn about the protocol, which I'm sure you guys have been anxious to learn. You got a copy in front of you. I'll tell you guys, this protocol used to look different. We've done some revamping. I think it is a lot more streamlined, straightforward now than it was in the past. And I'm glad that we got this approved for today so that we could present it today. We're also going to do some cases to try to reinforce what we will learn about the protocol. And then we'll get into some logistics and hands-on equipment training. So I'm going to do the first 2, and then Bailey will cover the last 2. All right, so the much-awaited protocol, here it is. So you guys got a copy of it. I'm going to kind of walk through it. All right, so we see here at the top, it's not just pre-hospital blood, but it's also TXA, because anytime you're giving blood, you probably should also be giving TXA. The only exception to that is GI bleeding, which there's studies that show that there's worse outcomes if we give TXA in GI bleeding, so we do not give it for GI bleeding, but all the other indications. So what are the indications? You guys got a copy of it. I know you guys can see it, but if you can't see it in the back, we'll just kind of talk through it. All right, so inclusion criteria. So somebody's got to be in hemorrhagic shock. So that means you don't have enough blood because you're losing it either externally or internally. And it could be from any of the following. So typically trauma, either blunt or penetrating trauma. It could be from GI bleeding. So think, your cirrhotic patient that's vomiting, or lower GI bleed, bloody stools. And then postpartum hemorrhage is a big deal. Also, just regular menstrual cycles. Sometimes these patients can get into hemorrhagic shock and get a really low hemoglobin. Although typically they kind of decompensate slowly over time, and their vital signs won't be so bad. All right, so how do we determine? Well, we're going to break up into two different categories. So greater 15 and up, and then lower than 15. And so they've got to have at least one physiologic sign. Okay, so there's 4 different options here. And really, when you think about it, if you take out traumatic arrest, it's really just 3 options. Okay, so we made it super simple. They're hypotensive, they have a shock index that's high, greater than 1, or an end-tidal CO2 that's low, which is a marker of poor perfusion. All right, so let's kind of go through it. So a single manual, it's got to be manual, because we know that sometimes our LifePak 35 is not always, reliable. Sorry, Matthews. But you should always be checking with a manual just to make sure that it's accurate and everybody's on the same page. And then we've got an adjustment for pediatrics, right? So 70 plus double the age, or 2 times the age. So, you got a 5-year-old, so 2 times 5, 10, plus 70, 80. So your 5-year-old shouldn't have a blood pressure lower than 80. Right? Now, if you do the math, if you got a 0-year-old, right? 0 times 2, 0, plus 70 is 70, so it should never be less than 70, right? So that's that kind of, remember, systolic at any age less than 70 is hypotensive. Everybody with me? So for adults, 90, anything less than 70, single reading is hypotensive and would meet criteria. So that's a single criteria. Now remember, you got to suspect hemorrhagic shock before you use this, right? So if somebody's been vomiting all day and they've got a picture for sepsis, like pneumonia, right? That's not hemorrhagic shock, that's sepsis, right? So we treat that like sepsis and we give fluids and antibiotics, right? But if we suspect they're either bleeding internally or externally and they're hypotensive, now they meet criteria for blood. Make sense? All right, so we just don't want to give blood to the wrong patient. Now, that's going to happen, okay? I would rather you guys give the blood and it not be the case that they need it, but as long as they meet the criteria, you're covered, okay? So just know, as we get used to this, we're going to kind of sharpen the saw, we're going to get better at this, but there's going to be mistakes, and that's fine, okay? All right, so shock index. I know this is something that may be a little bit of a new concept. It's actually pretty sophisticated when you think about it, because when the patient is hypotensive, right, when they lose blood, their body's going to compensate. So what's the heart rate going to do when you lose blood? It's going to go up, right? And so that's accounted for in this equation. So the equation's down here, heart rate over systolic. This always messed me up because normally systolic goes on top, right, in the equation, right? Systolic over diastolic, right? And so now it's on the bottom. So just kind of know where it goes. So think about it like this. If your heart rate is really high and your blood pressure is really low, what does that fraction look like? Is that a big number or a small number, right? 8th grade math, right? Fractions. It's a big number, right? And so if that shock index is high, greater than 1, meaning those two numbers match. So 100 over 100, right? Heart rate 100, systolic 100. What's your shock index? It's 1. So you do meet criteria at that point to give. Everybody with me? So now let's make it even more aggressive. So you got a heart rate of 150 and a blood pressure of 50, right? Is your shock index over 1? Absolutely, right? That's a sick patient. You don't need to calculate a shock index to know that. So just remember, we're not expecting anybody to do math in the heat of the moment when you've got a bleeding patient. Just look at the two numbers. Are they approaching each other? Are they almost the same? And if the heart rate is above the systolic, you automatically have a shock index greater than 1, okay? Some studies say 0.9, and we decided to do 1 because the math is easier, right? Calculating 0.9 in the heat of the moment. Now, having said that, ESO will automatically calculate this for you, okay? So you get a patient that's, blood pressure we'll say a heart rate of like 100, and their blood pressure is like 110. technically doesn't meet criteria yet. But you're going to keep an eye on them and wait for them to maybe decompensate. And then maybe as you're documenting ESO, you're like, oh man, their shock index is 0.9. We should probably keep a close eye on this patient because maybe they've got a source of internal bleeding from an MVC, and we're going to maybe give them blood at some point. Okay? Questions on shock index before we move on from that criteria? All right. End-tidal CO2 is our next criteria. And this is important because it's a surrogate marker of poor perfusion. We use this in sepsis, right? So when end-tidal CO2 is low, that's a marker of poor perfusion to the organs, but not because of blood loss in the case of sepsis, but because of vasodilation and inflammatory response from the body. So that's just a general marker. Now this can change in the short term, right? If you breathe really fast, what will happen to your end-tidal CO2? It'll drop, right? Because you're breathing off CO2. But what we'll see is that that's only short-lived, and then it will start to climb back up, okay? So in the setting of hemorrhagic shock, that end-tidal CO2 will probably be low because you don't have enough blood to give to the organs, and so they're not producing CO2 at the cellular level that then comes back through the lungs and is measured on your prongs, okay? Everybody see that? All right, are we going to give blood to cardiac arrest, traumatic cardiac arrest? Yes, but only non-asystole, right? Because what do we do in asystole? Traumatic cardiac arrest. So guy gets in a crash, blunt trauma to the chest, we've put the monitor on him, no pulse, asystole. What do we do according to the protocol? We call it, right? Because their chance of survival is essentially 0, okay? All right, so what if they're in VFib? What's your next step? Same patient, blunt trauma to the chest, VFib. Well, we could put pads on and shock them, right? Then our 3-hole punch, right? Finger thoracostomy, pericardiocentesis, plus or minus do ultrasound first to see if there's blood around the heart to determine if it's even necessary to do a pericardiocentesis. And then we're doing all of our typical trauma stuff, right? So airway, right? And then breathing, thoracostomies, circulation, pericardiocentesis, right? So we're just going down the line of our normal ABCs that we know. All right? And then, of course, we would give that patient blood because they're not in asystole. They're in VFib. Now, probably more likely what you're going to see is PEA, okay? So you're going to have a patient that has blood loss internally, and they're in PEA because they've got a good pump. It just doesn't have anything to pump, right? It doesn't have any blood. Everybody with me? All right, so can you give it to pediatrics? Yes. How young? Doesn't matter, as young as possible, okay? We're gonna need the dosing for that though, okay? All right, so obviously contraindications, if somebody doesn't want blood, like typically Jehovah's Witness, right? This is gonna be a tough call, right? So you get somebody who is unconscious, they clearly meet criteria for blood, they're hypotensive, they're tachycardic, they meet the shock index, maybe their end-tidal CO2 is low, right? So we know they need blood because of, let's say, GI bleeding, right? And then the family says he's Jehovah's Witness. That's probably gonna be a med control call, right? Because we need to get everybody on the same page to make a decision moving forward, all right? Okay, we adjusted this a little bit from the video. So we just added hemorrhagic shock, plain language, it's poor blood flow to vital organs, okay? And so you can read this to our conscious patients that have medical decision-making capacity, and if they don't, then we're going to assume that they would want blood because it's generally a good idea. All right? Yeah, go ahead,
It's
Joe.
like a Miranda rights kind of deal where we have, if they are conscious, we have to read it verbatim.
You should, just because there is some risk involved with blood, right? And so we're going to talk about the complications and the kind of adverse effects. But generally, blood is very safe because we're not going to have, and we're getting a little ahead of ourselves, but the ABO incompatibility is not really an issue with 1 or 2 units, especially if you're giving type O blood. So we should be good on that in terms of like serious complications.
So if it's a chaotic type deal, we forget to read that to them and we do it anyway. It's not the end of the world.
Correct, yeah. Use your judgment. if the patient's decompensating, patient care always comes first, right? And then consent, right? So we walk this line all the time. This is not a new concept for us. If a patient is really sick, we don't say, are you okay with intubation? Are you understanding the risks and the benefits? We intubate because that's what the patient needs, right? So don't second guess yourself, do the right thing for the patient, and I'll always back you up. Okay, very good. So that's that. And then let's move on to the second page. So now we've kind of diagnosed, or we've kind of determined that the patient meets criteria. So now, how do we actually give the blood? So we're going to prepare all your equipment. So you basically need the blood, right? You need the warmer. You need the pump, or the hand pump, or the gun, as we call it. The phaser, that's right. Yeah, we're staying away from gun. You don't say, give me the gun, right? On scene of a suspicious, maybe it was already a shooting and now you're asking for a gun, right? So, and then, all right, so, and then we need the tubing, right? And so we're gonna get all of our stuff ready. We wanna make sure that we have 2 paramedics double check this blood is not expired. Now EMS 1 is going to be checking every day to make sure that the blood is not expired. And we're gonna kind of know a heads up, and we're gonna make sure that's at a temperature, make sure that tag has not turned blue. But these are all things that we can check. So make sure that the bag's intact and it's not leaking. But these are, again, things that EMS 1 should be doing, but the more people we have eyes on it, the better it's gonna be, and we never give damaged or expired blood, or blood that has come above temperature. And make sure there's no clots in the bag. This is pretty rare to happen, but it can happen. All right, so now we're gonna break up treatment into 3 different groups. Okay, so because there's a pretty broad variation among these. So for adults and down to 6 years old, it's gonna be the same. So they get 1 unit of whole blood. That's our priority. We'd like to give whole blood if we've got it. There may be times where we can't resource whole blood, and so we're gonna give PRBCs only. PRBCs are just the red blood cells, whereas whole blood, of course, has both the platelets and the clotting factors in it, and is gonna be superior to give. All right, so one of the big questions is we give a unit of whole blood. The patient's still hypotensive. What do? Well, we got another unit, right? We got 2 in the field, but that's all we have. And so we can give another unit, and we're going until we get a goal of what blood pressure? 90 or greater. Now, if there's 6 to 14, then that changes. So now we're gonna still use our pediatric hypotension formula, right? 70 plus double the age. And if they're pediatric, we're gonna lower the dose down to 10 mLs per kilogram. So we may have to do some math in the field, and that's all right, okay? And just remember, if you don't give the exact, right, let's say it calls for 300 cc's for your pediatric patient, 300 cc's of blood, and you give 350. It's not the end of the world, okay? So this patient will be fine. In fact, based off their blood pressure, they may need another round of blood, okay? All right, so as we talked about in the video, oftentimes calcium can get low in the patient because of the citrate preservative that will bind the calcium in the patient's blood, and so we always want to give calcium when we give blood. And you can see the dosages there, pretty straightforward. Also TXA, with the only exception being GI bleeds. We don't give TXA for GI bleeds. And you can see the dosages there. All right, any questions so far? Go ahead.
I know a lot of systems, temperature monitoring with blood transfusions is a big thing.
Temperature monitoring of the patient?
Mm-hmm.
Yeah.
For us.
Yeah, so that's a good call. So the most common complication is going to be a small fever, mild fever, maybe some chills. And this is just because the immune system is reacting to this foreign tissue, basically this blood. And so what we can do is just monitor for that. Usually the symptoms are pretty mild. You can give Tylenol en route. Keep the blood transfusion going, okay? Continue to monitor the patient and then just let the hospital know what happened. So actually in the hospital, sometimes what they'll do is they'll actually pre-treat with Benadryl and Tylenol before every blood transfusion. for these patients that are like, chemotherapy patients or chronically ill patients. So we're not recommending to do that. We're saying just treat it when it develops. Our transport times are slow or fast, and so we don't have a lot of time for this to develop anyway. All right, good questions. All right, so moving on to the third and last page. So these are the complications. Now, I know this seems like a lot because we're learning about these complications. I can tell you in the systems that I've asked around in, so Frisco, Parker County, Saxe, Arlington, I haven't heard of a single complication, okay? So I just want to give you guys an idea of how much you should expect this. It's pretty rare, okay? The most common one, right, is the top, the febrile fusion reaction. This is one we were just referring to, was, a little bit of a fever. You do not have to stop the transfusion for this, and it's about, 4%. So, I mean, we may never run into this, depending how long, how many blood transfusions we're doing. So the others, the allergic reaction, we know how to spot that. Hives is the thing to look for. That's the kind of classic allergic reaction to blood. And we know how to treat that. We can give Benadryl, we can give steroids. If they get really sick, we know how to give epi, okay? Like airway compromise, tongue swelling, stridor, we can give epi. IM, of course. The hemolytic transfusion reaction, this is the one that should not happen for us because we're only going to be giving type O blood. So you shouldn't have that ABO incompatibility, and that should not be an issue. If that happens, it means that somebody at the blood bank mislabeled the blood, which is going to be a huge ordeal and investigation. So the people at the blood bank are meticulous, are just very, very careful not to make mistakes with these. They test and retest and verify and confirm, and a second person confirms. This is very, very strict, the way they handle this, which is good for the patient because we don't want to cause harm to the patient, but also makes it difficult to carry blood because we have to keep really high standards, right? So that we keep our patients safe, right? We never want to cause harm to the patient. All right, infection, super rare. If somebody ever comes back to us and says, hey, we had a patient that they had a blood donor that tested positive for HIV or Hep C, there's this thing called the window period where they may have given blood that had some type of virus in it, and then we gave that blood to a patient. So there's a process for that. It's called a look back, and we've got a process in place for that. So not for anything for you all to worry about, but just know that we have a process in place to cover that. All right, so I know we talked a lot about females of childbearing age. Remember, for males, it's not an issue to give them positive blood, Rh positive. So we're giving O positive, right? So the O part, again, is the ABO part. That's the one that can cause acute hemolytic transfusion reaction. That's the dangerous one, the deadly one. So it should not happen because we're giving O, but then the Rh part of it, this will have the Rh because that's the only way we can source blood. Rh negative or O negative blood is very, very rare and hard to come by. So that's why we're not giving it. So if you're giving Rh positive blood or O positive, which is what we're giving, to males, not an issue, okay? Because they can't get pregnant. Everybody cool with that? All right. Just checking. All right.
We'll discuss later. We can talk later.
Yeah, we'll talk about it later. It's only for childbearing. So if you got a woman who's over 50, right? Not childbearing, right? Not an issue, okay? And under 10, according to most standards, not childbearing, okay? So we're good there. So it's really only consideration during childbearing, and it's really not for this pregnancy, it's for the next pregnancy, okay? All right, here's the bottom line for Rh alloimmunization. If the patient's in hemorrhagic shock, they have a really high percentage of death. They have a high risk of death. We're not going to wait and worry about this Rh alloimmunization. We're going to save the patient's life by giving them blood. Everybody understand? The joke is patients, when they're surveyed, they would much rather survive rather than deal with the Rh immunization, okay? All right. We all know we're going to go to a trauma center when possible. We shouldn't have a problem here. We've got 2 trauma centers. And then obviously if the patient's bleeding, we'll want to put back in what they lost. So crystalloids are inferior. We want to give blood always to avoid the dilutional coagulopathy or thinning out of the blood. Let's say you have a scenario where you're on scene. You know the patient's going to meet criteria. They're hypotensive, shock index greater than 1. Their end-tidal CO2 is low. They have signs of bleeding, either internally or externally. So we know when to give blood, but EMS is delayed. EMS 1 is delayed. Can you give TXA now? Absolutely. Why wait, right? Can you give calcium now? Absolutely, right? So another scenario is the patient, well, actually, we'll get into this in a case, but we'll just kind of mention it briefly now. You've got a patient who looks sick. You think they're probably going to need blood, but they don't yet. They're right on the border. They're almost ready to get blood, but they don't quite meet the actual criteria yet. What should you do in that situation? Well, you can take the cooler. It's called an APRU. The cooler, put it in the unit. It'll stay cold, and then that way, once you need it, you've got it. Does that make sense? So that way, EMS 1 doesn't have to stop and start. They can just give you the cooler. It's portable. It's pretty heavy, but it's portable. All right? All right. I can't tell if you guys are being quiet because you understand everything and you feel like you have full mastery of this, or if we're just being shy this morning, except for Dunn. Dunn's doing great.
Hey, Doc, are you going to touch on pediatric?
Yeah, any specific questions about
Like
peds?
transport, destination, like our closest trauma center,
Yeah.
or trauma hospital for pediatrics would be Cook's.
Correct.
I believe they're a level 3.
Yes, correct.
So what are the expectations if we're giving blood to pediatrics?
Yeah, I would say if it's a multi-system trauma, and this is going to be like a legitimate trauma, they're probably going to need to be flown to Children's Dallas because they are the only level 1 trauma center or the closest level 1 pediatric trauma center. And so we could still give them blood. And the good news is that a lot of the air ambulance, flight crews are familiar with blood, and they can go ahead and take over that blood.
So a lot of our common practice now is we'll get them to Baylor or MCM and then allow them to transport them out. Is this going to be a game time decision, phone call to med control?
Yeah, great question. I would say, yeah, so the protocol states that if there's any concern for airway, right, then take them to the closest, regardless of the specialty need for, in this case, a pediatric trauma center. So if you've got airway compromise, you're worried about that patient, just take them to the closest. We will stabilize and then transport. So it is a judgment call. But if you are, let's say, way up north in our jurisdiction and you're still, let's say 20 minutes away from the hospital, you might justify in that case, hey, this might be a good one to fly out. If it's, and then, there's so much that goes into this decision. Is the weather appropriate? Do we have an LZ set up? How do we orchestrate this? So, but yeah, generally, if you brought it to Baylor or to MCM, I think you'd be fine.
But what I just want to make a point, guys, is we don't live in a box, and so it's not always this or always that. Let's keep all options on the table, and when you make a decision, it's going to be a justified decision based on the clinical decision making that's set for. So don't live in a box that we're not flying anybody anymore. That it needs to be the appropriate conditions.
Yeah, great point, Chief. All right, any other questions? There's a mention there about beta blockers and calcium channel blockers. Just remember that's going to affect your shock index because your heart rate's going to be blunted, so you're not going to get as much of a response with the heart rate. And so some of these patients are usually the older patients. They also are going to not tolerate hypotension very well. So older patients tend to live at a higher blood pressure just because of time. And so they will start to need blood transfusions probably around systolic 110, 100. So if you've got somebody that you think looks horrible, they're pale, they're becoming less responsive, but their blood pressure is 100 and their shock index still looks good because they're on a beta blocker, call med control. I'm going to approve it every time. If you think they look sick and you're worried about them, I'm going to say go ahead and give blood. If it doesn't end up needing blood, we'll deal with it later, okay? Go ahead.
We've had some shootings stuff with multiple patients.
Yeah.
If that's the case, then like we kind of have to hash it out and seeing like prioritize giving blood to one patient and kind of spread them all between
Yep.
patients and stuff. Or
Yeah, so this is the classic conundrum of triage, right? So you're going to do the most good for the most amount of patients. So that's the guiding principle. That's the best advice I can give you. The advice that would be specific for that would depend on the details, right? So, but what I would say is use 1 unit of blood. If you think you've got multiple patients that are going to need it, then give it to the sickest one first, right? As long as they're not so sick that they're in asystole. Of course, we're not going to resuscitate those. And then act accordingly. This is a game time decision, and I wish I had a perfect answer for you, but the only reasonable answer without knowing details is triage. Yeah, great question. By the way, so just kind of thinking of scenarios. So you get a really sick patient, whatever the hemorrhagic shock causes. We just used our 2 units of blood. So now we have 0 blood in McKinney. How long is it going to take for us to get new blood? It should happen fairly quick. But again, this is a supply and demand thing. So just like medications go on short, back order, that can happen with blood too. So our blood bank has been phenomenal so far. They have been really good in supporting us, and they're going to try to have the blood available all the time. But there are going to be times where we don't have blood. Okay. Now, going back to the start, we all are going to have a higher index of suspicion. And I hate that term because everybody says, I have a high index of suspicion. It's like at some point, everything's a high index of, so it all becomes the same again. But start to think about opportunities to give blood. And EMS 1 is also going to be doing that. And don't feel like you have to call off EMS 1 if they're en route to a major accident, because they can respond and be there just in case we need the blood. Okay, because they've got the blood, they're storing it and cooling it. And we made that decision because of resources, but also it's really hard to train everybody on how to keep the blood and use the cooler and document daily checks. So we're offloading you guys as frontline paramedics from that task. So only EMS 1 is going to be responsible for that. But yeah, we should always have blood. There may be exceptions, and we'll try to communicate that. If we get a sick patient that uses up our 2 units, then we will we'll notify everybody. All right, good questions. All right, so to kind of bring home the point, I've made some cases here, okay? So case number 1, we've got a 75-year-old who's got a history of CHF. He's on Lasix. He's got AFib. He's on Eliquis. Maybe see where this is going. Shortness of breath and black diarrhea for 3 days. All right, so when you do your physical exam, you see respiratory distress, you got clear lungs, and the GCS is 15. All right, there's your vital signs. What's the most concerning of those vital signs? The SAT's pretty low, right? 85%. Blood pressure doesn't look too bad. Pulse rate a little bit fast. Multiple explanations for that. Could be from CHF exacerbation, increased heart rate to try to increase his cardiac output. End-tidal CO2, a little bit low, not too bad. All right. So what's your next move? So this is the class participation part of this. All right. So we're going to do multiple choice. If only life was this way, where you had the patient in front of you and you had multiple choice. So who wants to do CPAP? Who wants to do push dose epi? Who wants to do whole blood? Who wants to do nitro? Now you want to go back and look at the vital signs? All right, as much as I appreciate all of the mumbling, knots, what do you want to do? CPAP. I agree. We do CPAP. Waller doesn't even know yet. Okay, so then in or out with CPAP, the patient has a large, black, bloody stool. I'm sorry, I don't have a picture of that. He now becomes less responsive and pale. Now, you repeat vital signs. We're still 15 minutes away. All right. Good question. All right. So now what's your next move? All right, we got to vote for epi. I don't think it's unreasonable. We really still don't know, right? So let's go back to our assessment. Does this guy, what's the underlying cause of this patient's shortness of breath at this point? We really have two contenders, right? CHF exacerbation on the one hand, and GI bleed on the other hand. Remember, what does blood do for us in the body? It transports oxygen, right? So that's a little bit of a hint, right? And his lungs were clear. So, all right. So I would say this guy does meet criteria at this point for whole blood. Okay?
How do we see that the poop is black? Like, is he naked?
It comes out of his shorts, and it's on your gurney now. All right. So what protocol criteria did this guy meet? Shock index greater than 1. Systolic less than 90. And end-tidal CO2 less than 25. So really, he meets all of them. All right, so if you have a patient that meets one criteria, they can get blood. But if they meet all three, then you should really think about blood, right? Because now your confidence level is going up even higher that this patient needs blood. Does that make sense? Okay. All right, so some key points. Anemia can be a cause of shortness of breath, right? Because remember, blood carries oxygen, right? I mean, it sounds silly when you say it out loud, but I always forget when I'm in the hospital and I'm listening to my lungs sound clear, and then there's no pneumonia on the chest x-ray, there's no febrile symptoms, there's no concern, and then the usually, menstruating female says, oh yeah, I've had these heavy periods, and I check the hemoglobin and it's 5, and it's like, that's why you're short of breath. Everybody with me? All right, this is a real thing. So melena cannot be hard stool, okay? So I know it sounds weird to ask the patients, and sometimes patients are like, I never look at the poop, I don't know what it looks like, right? But if it's loose and black, that's melena. If it's hard and black, what could that be? Too much iron supplementation can cause constipation and black stools. Everybody taken Pepto-Bismol before and saw their stool turn black, right? Your tongue turns black too if you take enough of it. The chewable tablets, right? And then sometimes, certain foods that are like high in pigments like beets and Takis and those kind of things can sometimes turn the stool black. All right, so again, the pre-hospital blood criteria, you just need one physiologic sign, but if you've got more than one, you want to really monitor that patient aggressively and treat aggressively. Have you guys heard of this concept of we match the level of sickness with our treatment? What that means is if a patient's only a little bit sick, we're only a little bit aggressive. Patient's really sick, we're really aggressive. And so this is a concept that kind of runs through all of what we do. And so just like an allergic reaction, mild reaction, we just give Benadryl, right? Maybe some steroids. Severe anaphylaxis, well, we're going to give the big guns, right? All of those things plus epi, right? Does that make sense? So that's the concept there. All right, and then of course some BMs indicate impending doom. So I know this sounds funny, but this is real.
Truck 9, for priority 3, 2200 Taylor Burke Drive, East Parking Lot, City of McKinney Public Safety Building.
Oh.
Cross streets North Central Expressway southbound and Community Avenue.
So, slip and fall. So I'll tell you guys that this is actually a thing, okay? So I've had this happen multiple times in my career where the patient has GI bleeding, their vitals look good, they have a massive bowel movement. And I know it sounds strange, you're like, oh, it's just a bowel movement, no big deal. But remember, that blood came from somewhere. It came from the GI system. And once you evacuate the bowels, now that bleeding vessel that's in the colon or wherever it's at can then start to hemorrhage in, and then they start to actively bleed internally. But you're like, but the blood's already out. Well, yeah, now they're bleeding again inside. And so when they have these bowel movements, take it seriously, okay? So these bad bowel BMs, these black tarry stools, that can sometimes mean, hey, this patient's about to get really sick. So watch them like a hawk, repeat vital signs, look at how are they feeling, right? Are they confused? Are they pale? Are they diaphoretic? And then that one might be a early indicator that this patient is getting sick. All right, so now we're going to do some quizzes, okay? So you guys read through. Well, I'll kind of read it for you. Okay, so according to our protocol and the literature, including Pamper and the Deeb article. Oh, so by the way, who watched the video? Okay. You may not know some of the answers to these if you didn't watch the video. I would encourage you guys to watch the video, the lecture voiceover that I did, and also the conversation with the trauma surgeon, Dr. Vaughn, okay? So that's gonna help you understand pre-hospital blood, so please watch it. All right, so according to these articles, what is the primary reason we prioritize low titer whole blood over crystalloids? B is correct, good. All right, so we know that according to Pamper study that blood was superior to saline for hypotensive trauma patients. All right, number 2, what's the most appropriate management for potential hypoglycemia when administering low titer type O whole blood in this patient? D is correct. Everybody good on that? What's ROGAM for? That's for the RH, and that's only for females. All right, so remember, citrate binds the blood calcium, not only in the blood product, but also when we give it to the patient, that citrate goes into the patient and then starts to bind up their blood calcium, and that can lower the blood calcium. All right, so okay, good. So remember that once it turns blue, it's gone over 10 degrees Celsius, and it's permanent. It cannot turn back, okay? So if it's blue, it's bad blood, okay?
And according to the blood bank, this will be the end-all be-all. So even if we have a great temperature tracking that goes on for as long as we've had that blood and we can prove that it's kept within the temperature, if that thing's blue, the blood bank will... That's the holy grail of temperature monitoring for the blood bank.
Yep, so if that happens, you put it in a biohazard bag, mark it quarantine, and then it's got to go back to the blood bank to either be, disposed of or checked. All right, question number 4 here. Which of the following is required for an adult, so 15 or greater, to qualify for pre-hospital blood under our protocol? Yep, good, A. All right, so it's just basically, do you know the criteria? All right, number 5, so calcium gluconate dose for a pediatric patient, 0 to 5. You've got it right in front of you if you need it. All right, so it's B. All right, number 6, you got a 20-year-old female in hemorrhagic shock from postpartum bleeding. We know she's RH negative, so that's our risk. What should we do? Good. All right, remember, hemorrhagic shock is dangerous. It's life-threatening, high risk. RH immunization, if some of you remember, the chance of something bad happening to a future pregnancy fetus is only about 0.3%. It's really low. Hemorrhagic shock mortality rates are way higher than that, okay? Depending on how far along the patient is in that hemorrhagic shock continuum. So we always treat the patient appropriately. All right, number 7, patient gets pre-hospital blood, has mild fever and chills, and a 2-degree temperature increase. Which complication did they have? Good. What if they had an allergic reaction? What would we see typically? Hives are the kind of classic one. And then hemolytic transfusion reaction, how would we recognize that? Because they could have fever, but they're also going to get really sick. They may turn jaundice, they may have DIC, bleeding at their IV site. They're going to look way sicker than before you gave them the blood. And it does usually happen within minutes, okay? But again, that one is not supposed to happen because we're giving type O blood. Infection, will you see any, if we gave them blood that was improperly tested and had HIV in it, and we gave the blood to them, what would happen? Probably nothing. And you wouldn't know for several months that they had any symptoms. All right, so yeah, remember febrile transfusion reaction is only about 4%, and just a little bit of a rise in fever, but generally they do fine. What do we do for that? We give them Tylenol, okay? All right, number 8, so this is the 30-minute rule. So if a unit of whole blood is removed from the cooler for less than 30 minutes, what's your next step? Less than 30 minutes. Okay, see? Good, yeah, it can be placed back in the cooler, but only if the sticker is not yet blue or hasn't changed to blue. So blue is bad, means the temp rose above 10 degrees Celsius and cannot be used. All right, you guys ready for the next case? We have an 80-year-old man here, MVC with major damage and has abdominal pain. This is actually the case we did for Baylor McKinney yesterday. So he's got a history of hypertension and he's on metoprolol, but he doesn't use any oral anticoagulants. By the way, just side note, the term blood thinner we use inappropriately a lot, so really we want to know about anticoagulants, not blood thinners, because nobody really knows what blood thinner means, right? You say blood thinner, some people say, oh yeah, I'm on aspirin. You say blood thinner, and some people say, oh yeah, I'm on Eliquis, right? So remember, antiplatelet medications, aspirin, Plavix, clopidogrel, Brilinta, right? These are antiplatelets, whereas anticoagulants are much stronger blood thinning properties. So those are your Eliquis, your Xarelto, your Pradaxa, your warfarin, Coumadin, okay? All right, so on exam, physical exam, you see abdominal bruising, but GCS is 15. All right, vital signs. How does everybody feel about those vital signs? Not too bad, right? All right, so what's your next move? All right, multiple choice. If only life was this way. Okay. All right, I agree. Take the cooler with you because this guy may have kind of occult shock at this point and he may get worse. All right, so en route, he gets more abdominal pain. He becomes pale. And now, here's your vital signs. All right, now what do you guys want to do? Give blood. I agree. And look, we give him blood, and look at how good he's doing now. He's so happy. All right, so what were your criteria to give blood? Shock index greater than 1. End-tidal CO2 was low, indicating poor perfusion. Good. All right. All right, so some key points about this. When in doubt, bring the cooler, okay? Take it with you so you have the option to give it en route. Shock index can be deceiving, right? That blood pressure didn't seem so bad, right? But just remember that you got to look at the blood pressure in light of the heart rate. Also, patients on beta blockers and calcium channel blockers can have a blunted tachycardia reflex, meaning that normally their heart rate would be 120, but it's only 100 now because the beta blocker is slowing it down. All right, and anybody over 65, they're going to have less physiologic reserve. This is kind of what I was referring to earlier, that they will probably need a blood transfusion at a level of 110 systolic or maybe 100. But in our protocol, we're going to keep it simple. We're not going to make, but just I want you guys to know in the back of your mind, you got somebody over 65, their blood pressure is 110, their heart rate's 110. They meet criteria, but if their heart rate was 100, right, they don't quite meet criteria yet, but you're gonna watch that patient like a hawk because they're probably gonna decompensate. So some systems, they would say, go ahead and give the blood. We're gonna keep it simple to keep the protocol simple. And then just watch that patient, and once they meet criteria, we give them blood, all right? By the way, we were talking about bringing the cooler with us. Remember, you guys are going to have the blood tubing and what's called the CDU. We'll get in that later, but it's the disposable part of the warmer. This has the coils inside that warm the blood. And then EMS1 will bring you the actual battery and the warmer part of it that clicks into the CDU. So remember, you can set up everything in advance before EMS1 gets there. So we don't have to wait. And so, Bailey, how long did it take us yesterday to set it up?
Under 2 minutes, like a minute 10.
Yeah, so pretty fast, right? So, pretty cool. All right, any questions? So that's all I got for you guys. All right,
One.
yeah, please.
I think I know the answer, but I just want to make sure it's.
I think you do too, but go ahead and answer.
Unmistakably clear, because I know
Yeah.
I'm already getting questions from folks,
Yeah,
and the whole rest of the department will ask me probably the same question. As far as timing goes, on the calls that EMS1's maybe not dispatched to
yeah,
with us, if we recognize they need blood, the EMS1 says, hey, I'm 12 minutes from your scene, and it's a 4-minute transport to the ER. Are we prioritizing waiting for the blood, or are we going to go ahead and go to the ER and transport to the ER?
great question. Absolutely great question. Okay, so let me just kind of restate it for the recording. So the question is, if you think patient meets criteria, but EMS1 is delayed, you think you can get to the hospital faster than EMS1 can get to you? Yes, go to the hospital. The point is to get the patient the blood that they need as soon as possible. And if that means you take them to the hospital, that's the best outcome. Don't delay transport in order to give pre-hospital blood, okay? Now, having said that, there are times where you can start to go en route to the hospital and you're still 15 minutes away, and you can have EMS1 meet you at an intersection or some place, and all they need to do is literally throw the blood into the back of the unit, and then you're off and running again, okay? Chief?
I was just gonna comment on that. Frisco shared an example, multiple examples where they carry theirs on the battalion chief ride, and the battalion chief would meet him at an intersection. And I think of a situation, let's say in 7's district, where beginning next week, EMS1 will be located at Station 2. And so if EMS1's shooting down 380, you're over in 7's district and you're going to Baylor, maybe he meets you at 380 in Custer, you pull over real quick, he gives you the blood, he's waiting there already for you. That blood is infused before you get to the hospital. Okay, when we're talking minutes, if it's that important to have blood, getting it on sooner is equally as important. So you can have everything set up, EMS1 just gives you the blood, you spike it, you go, and it's infused by the time you get to the ER. So those are options as well.
Yep, absolutely.
Is our response matrix going to change at all, the EMS1, now that we have blood? Are you
Yep.
going to respond more calls or different?
I've got a meeting, I've had 3 meetings, 2 of them canceled because of weather, so with dispatch to get that fixed.
Yeah, so I think the ones that are going to be easy catches are the major MVCs, right? Because these are the patients that are going to be either entrapped, right? We're going to have to extricate them. That is where pre-hospital blood shines, right? Because they have no chance of getting to the hospital to see the OR. They're going to get blood in the field until we can extricate them, right? Because remember, the chance of survival goes down, every minute that goes by, we lose, our 2% of our chance of survival. So if we're extricating for 30 minutes, right, we may have missed our window of opportunity. So if we can give blood while the patient's entrapped, I think that's an amazing way to give pre-hospital blood. That's kind of the heart of why we give this. But even if we're on a long transport, there's still a lot of benefit to do this in route. So. Yeah, good questions, guys. Anything else? Yeah, go ahead, Curry.
And we still have it in there, it's still a game day decision. Like, the guy had HUB 121, he had a liver lacerate, got shot to the liver, got shot to the pelvis, he got shot 4 times. based on the injuries he has, is mostly penetrating trauma stuff. We're not gonna replace what he's got and stopping it on the highway to go versus getting him to the OR and within 9 minutes of touching him.
Yeah, again, it's a judgment call. So if you think that that EMS 1 will intercept you and you can get blood infused before you get to the hospital, I think the call is to go ahead and do that. Go ahead and give the blood. If you don't, then that's fine, and then you just document why you made that decision. And remember, guys, we're still doing all the things that we normally do, right? We're still packing wounds that are on the trunk. We're still putting tourniquets on, right? So stop the bleeding before you put blood in, right? Because guess where that blood's going to go after you put it in? It's going to go right back out. So, there's some places that we can't compress, right? So liver lacerations, right? Or spleen or internal bleeding. So we can't fix that in the field. We don't have an OR in the field. So we can give them blood. We can allow the body to clot off that injury, and then they can go and get it fixed definitively. Okay, so we're trying to get them to the hospital alive, and sometimes they'll actually stop the bleeding process because of the blood that we gave them.
Hey, Doc, well, I'm gonna make one more point and I'll quit hijacking your meeting. When people ask you questions like, hey, we have to do this or we don't have to do that, I want to share this analogy with them. As everybody loves the fire service, everybody loves being a fireman. Nobody wants to be that guy that the captain tells them, pull an 1 3/4 to the front door. I want you to take a Halligan and an axe. We're going to force it outward swinging, and then we're going to do a right-hand search. I want you to take it 3 steps to the left. Nobody wants that. Everybody wants to say, hey, fast tack front door, and let you make the decision on how we're going to get that done, right? That's the way we need to be critical thinkers. So and as paramedics, it's no different. With this blood stuff, we could say, well, do we need to meet EMS 1? Do we don't meet EMS 1? Do we wait for them? Do we not wait for them? Do we fly them? Do we not? Guys, we're not going to get off into the weeds on what size hose line we should pull. What we need to do is be critical thinkers and see, what does this patient need now? And am I giving away the option of 70 miles an hour down 121, I could be at the door in 3 minutes. If I pull over hard and meet EMS 1, I'm going to delay it 6 minutes. No, I'm making a clinical decision we're going. That's where we want to be. We want to be critical thinkers, make that decision, pass that on to the medics that we're going to be working with, and help them understand the importance of opening up that mind and getting out of that box a little bit. Be critical thinkers within the protocol.
Yeah, 100%, guys. I mean, I trust you guys to treat my family, to treat me. So when you guys are in a predicament, if you need help, call me on med control. But generally, I'm probably going to tell you what you already know. And if you just need to bounce an idea off me, that's fine. Let's do that. But just know that, like Chief is saying, trust your judgment. You know the goal. You know the principles to work with. Use the principles to accomplish the goal. And we're all going to be fine, okay? And if you make a mistake, tell me. I'm going to back you up, and we'll learn from the mistake, and then we won't make it in the future, right? So I always say this, but I'll say it again. So making a mistake is fine, as long as we learn from it. Making the mistake and not learning from it is unacceptable. We cannot do that. That's not an option, okay? But we're going to make mistakes, and that's fine, as long as we're doing our best, and then we're learning from them. But there's going to be, bugs to work out along the way. We're trying to get ahead of this to make sure that we're accounting for that. But there's still going to be things where we haven't thought of yet. So this is why we're starting with you guys, because you guys are the best of the best.
I love that you said that right as Parker County walked in.
I wasn't going to comment.
All right, very good. Yeah, let's take a break, and then we'll come back and get into the next section.
Be back in 10 minutes. A real 10.